Thank you all for joining us for what I believe is our fifth Mental Health Coalition Parity Series discussion. We have been trying to pull together experts to talk to you about their perspectives relating to how behavioral health coverage is provided under insurance parity rules that are regulated by both the state and federal government. And our goal is always to provide current information and to engage with representatives of providers, stakeholders, policymakers in the insurance industry so that we can all learn from each other. Because I think if we understand each other's perspectives and work together, we can find solutions to some of the struggles, I think, in the behavioral health space that everyone is facing. So let me talk to you a little bit about who we'll have on our panel today. It's more going to be a presentation. My name is Audrey Dunkel, and I am the chairman of the Mental Health Parity Committee. And on the side, I work at the Kansas Hospital Association. Our presenter today is Sunny Mickle, who is the Vice President of Government and Community Relations at Blue Cross Blue Shield of Kansas, and she's been there for 15 years, so very much the expert in this space. And then, of course, Amy Campbell, who is the lobbyist and coordinator for the Kansas Mental Health Coalition. Now, Sunny does have slides, and as you've heard some of the discussion, we'll make sure that those slides are available after the meeting. Amy will make those available in the next Mental Health Coalition agenda, which will be accessible on the Mental Health Coalition website. In addition, this is being recorded, and so this will be available on YouTube for you to share with your friends or go back and review as well. And last but not least, we will have time for questions after the presentation. Right now, all of you are muted. You can put your questions in the chat or in the question and answer feature. Just let me know your name, and so we will make sure as we reach the end that we can get those questions. Once we do open it up for questions, you can also use the icon to raise your hand, and we'll be watching the attendee list as well to make sure you can ask your questions. With that, I will turn it over to Sunny to get started. Thank you for being with us today, Sunny.
Well, thank you for having me here. I'm really excited about this discussion. It's something that's actually very important to me personally, also to the staff at Blue Cross Blue Shield of Kansas. We've been working, trying to be very closely involved in conversations that are happening at the state level for many years. And we've been working with providers and listening to them. I know it's frustrating at times when you're a patient or a provider and you are an expert in this field and you're providing your perspective. We do take all of that to heart and honestly work hard on creating policies and platforms that are going to be better for everyone, especially those of us here in Kansas. That's our priority. We are a local insurance company and the largest in the state. And we believe it's important for us to pave the way and provide access to care for everyone in Kansas, not just our members. So today I wanted to make sure I had an opportunity to just kind of tell you a little bit about what we've been doing in this space. And we're going to talk briefly, though, about how we've seen expanding behavioral health priorities work for us at Blue Cross of Kansas, and then jump into those mental health parity challenges and opportunities that I think all of us are dealing with today. And we will definitely have plenty of time for questions and answers and discussion. And I want to hear from all of you and your thoughts. So as we jump right into just what we've been doing when it comes to expanding behavioral health services at Blue Cross of Kansas, I can tell you that for many years, we've been paying behavioral health professionals that are treating students actually in the public school setting and some private school settings. We've also been doing other things in the community, but it really became apparent during the COVID-19 pandemic just how important it is to create more awareness and to treat behavioral health needs for everyone. It's not always apparent to many people that there are people struggling with behavioral health needs. And I think the pandemic highlighted that and raised it to a level of where we need to do different things for treatment and support. And those things are not readily accessible right now in many of our communities in Kansas. At Blue Cross, we actually experienced a 20-fold increase in our monthly telehealth appointments among the members. And that was something that we were not expecting. We've had telehealth services for decades. We've actually been doing telehealth services at Blue Cross of Kansas since the early 1990s. But we also knew that many times when we were going to deal with something like the pandemic, that we were expecting to see people using those services for more what we would see medical surgical type issues that they just could not access their say physician's office or a mid-level provider. What we were documenting and seeing though was that people were going in and requesting services online and actually connecting with behavioral health providers, or even when they were connecting with their primary care doctors, it was about a behavioral health issue. So we saw right away that we had to do something in the meantime to also help bridge that problem that we were seeing. And we just know there's a provider shortage when it comes to treating people that have mental health needs. So we tried to take some proactive steps to actually enhance what was happening already in the market, and to provide some guidance and direction for our members. One of those was creating a My Resource partnership. And that started in 2021. And when we did that, it's a company that actually is offering an online mental health provider referral service. And it's for all Kansans, not just our members. This is something that we wanted to make sure was available to the public, because not everyone has health insurance coverage, or they may have coverage that's more limited. And we wanted to be able to help people who were not sure where to go when they were struggling and needed help and wanted to find a provider. So this service is a search engine, but it's almost like Match.com when you're talking about trying to find a behavioral health provider. It matches a patient with a provider based on a host of factors. Those range from the location preference. Does the person want to meet with someone in person or have a telehealth virtual appointment? And we're trying to do this in a positive way so people don't always have to pick up the phone and call someone when they're maybe a little disheartened and don't want to even talk about the matter with someone personally yet. We also wanted to focus on addressing health disparities. We feel that's a big challenge and something that has been maybe focused on more sometimes in the medical surgical world and not necessarily always thought about in the mental health world. And we wanted to make sure that we were bridging that gap. So if people were looking for someone, a provider that is of a certain race or cultural background, or has a certain language, that we were providing that information in an easy way for them to connect and find someone that may have some similarities to them, and they wanted to be able to see that provider perhaps versus another provider. But in general, it was about connecting patients in a way that was easy for them to shop around. We did see success with this program, and we're still doing this to date. So far, we have actually had up through 2022, 34,000 unique website visits. So these are unique users that have actually gone out and touched the My Resource search engine. And we've actually seen people schedule appointments using the service directly. We started the service in October of 2021. And at that time, from that time on, we've had over 3,000 people actually schedule appointments. We also looked closely to see about our personal membership at Blue Cross, not just everyone else coming in, but those people that we know are actual members of ours, and can see those people. Some of them have logged in directly through our private portal, and we can see those numbers that way. So we've engaged and had over 6% of them that have actually engaged in this as well. And then scheduling appointments is not something that is always done through the service. People could also pick up the phone and do it, but what we've captured through the service has been under 1% on actually scheduling an appointment through the service. But actually those that are visiting that schedule an appointment page where they get that information to set up that appointment time has been pretty high. We believe, considering that people are new to using this technology, and it's not been something that's been promoted and advertised as heavily since it's still very new. But we've had over 15% of people just in 2022 actually schedule or go visit the schedule a page appointment. Also, something else we wanted to do really was talk more about the new state of mind when it comes to recognizing mental health and taking away that stigma. So those of us who work at the State House and have talked about this on a lot of our panels have been talking about that as part of the challenge, that people sometimes are afraid to talk about this, or they feel it's not acceptable or embracing it. That's part of the problem getting help. So we launched a campaign called The New State of Mind that was aimed to open this dialogue about mental health for all Kansans, and that it doesn't matter who you are, you could be facing this challenge. And it appears in all different ways. 2 in 5 Kansans actually experience a mental illness in any year. And in the first month of us launching this information on our website that's public too for anyone who wants to use it, we did see people utilizing our resource guides that we had out there, assessment quizzes, toolkits, and an entire wellness media library. So people could either use it for themselves or to share with others. Part of this connection is important for us because, again, it's not always the same for someone who's experiencing mental illness. They don't sometimes know where to go or think of where to go for services. We wanted to be able to have them reach out to others for that help. That gets us into mental health parity and those challenges and opportunities. It's still something that is newer, believe it or not, in the insurance industry. We have been dealing with mental health parity since the early 2000s, but the definition of mental health parity is evolving for insurance companies and providers, and that has presented some challenges and opportunities for us. So the actual federal Mental Health Parity and Addiction Equity Act has made it very clear that health plans, regardless of whether they are fully insured health plans and completely controlled by, say, a company like Blue Cross of Kansas, or a health plan that is an employer health plan that is self-funded or considered what is an ASO group. Those plans, if they cover mental health and substance use disorder benefits, then they have to make sure that any lifetime limits and annual limits and cost sharing limitations are not more restrictive than what they're doing on the medical and surgical side for their members or the people that actually own those plans. That has been the case for years, but it gets a little bit more tricky. And this is where it's a challenge for the insurance companies and where we're still evolving and really excited to be learning more about how we need to do this in a way that is transparent and meeting the standards that we need to meet under the law. And that next phase is when it comes to how do we actually report our mental health parity and show that we are complying with these standards. So back in December of 2020, the Consolidated Appropriations Act that was passed by Congress included language in there specifically about mental health parity, addiction, and equity act, and stepping up those mental health parity reporting requirements. And that all took place and took effect for us to be able to comply with these standards back on February 10th of 2021. So this language came out late December of 2020, and the insurance companies and health plans were expected to comply with this new testing requirement and reporting by February 10th of 2021. That's where the challenge came in because there wasn't a lot of information out there on exactly what we are supposed to report. And I'll talk more about that on the next slide. I also just wanted to touch base with everyone here and make sure that you understand that insurance companies like Blue Cross are also aware and following Kansas mental health parity laws. So we do have our own Mental Health Parity Act, and for fully insured health insurance plans, they must cover mental health treatment services. So I sometimes get that question about, does this plan cover mental health services? And I always reassure people, if you're buying a fully insured plan in the state of Kansas, it has mental health services. And in Kansas also, mental health treatment cannot be limited or restricted beyond the limitations or restrictions that we apply to any other covered service. So that is being watched very closely by the Kansas Insurance Department. Now, the challenge for insurance companies and where we are still continuing to evolve is under non-quantitative treatment limit requirements. So you'll see us abbreviate this later on in some slides as NQTL. This is the new piece of reporting and managing our data to show that we are complying with mental health parity. So we, as insurance companies, were performing mental health parity services. We were believing that the other testing and comparisons we were doing with our actuarial folks and staff were proving that we were complying with mental health parity. But this is an additional piece of reporting that the federal government has issued. And what they're looking for is for us to actually demonstrate that we are providing the same requirements in these cases. So for example, prior authorization, that's a big deal. I know that's talked about quite a bit with hospitals and providers. They want to make sure that if we have prior authorization requirements, that they're the same for inpatient and outpatient services, for mental health services, as they are for anyone who's also getting physical medicine, our medical and surgical benefits on the other side. So we can't do something different for prior auth with mental health and basically not say have a prior authorization on the medical side. So I want to reassure people we're doing that, but it's how do we report that in a way that is actually showing the data clearly to the government. We also have medical necessity requirements that are on our medical side of our health plans, and we cannot use anything more stringent for medical necessity definitions or requirements for mental health services. Formulary design is something that pops up quite a bit. We get those questions because there's sometimes a belief that prescription drugs for mental health services are placed at a tier or a benefit that is more expensive than someone else who would be getting another medication for a physical medicine ailment. But we have to monitor that and prove that as well, that we are keeping the formularies the same. Provider network tier design. That's something that I hear a lot with other companies. At Blue Cross of Kansas, we have our provider networks, and we don't usually place certain providers and say, well, this is a specialist and you have to pay a lot more for this service or things like that. So for behavioral health services, we see that as like a primary care service at Blue Cross of Kansas, but there are some other insurers out there, and not just in Kansas, other states as well, that may have different provider tiers. And when they do that, the federal government's looking very closely to see, are you putting behavioral health providers in a more expensive tier or a place where people are going to have more cost sharing to be able to obtain those services? Then it gets down to also just recruiting providers. We have a provider shortage for everything in Kansas, but especially for our behavioral health providers. So insurance companies are required to demonstrate that they have a network that is accessible. So if a provider wants to work and be a part of that network, we need to make sure it's the same for someone who's a physical medicine provider as it is for someone who is a behavioral health provider. And then also that our reimbursement rates are fair and at parity for both types of providers. Fail first step therapy protocols. This one is important too, because our insurance companies able to demonstrate that they're not making people go through and try medications that are not going to be effective for them, and make them fail on those medications and try to go through others and step up to the medication they actually need. So insurance companies are able to do step therapy, but it must be the same again for both medical as it is for anyone who's trying to obtain a mental health medication. Another big topic that I know we've talked about before with the legislature and in stakeholder groups and amongst providers and Blue Cross has been concurrent and retrospective review for services. And these are claims. Concurrent review is when you're actually, in treatment, and we're trying to demonstrate that what we're doing there is if we're looking at someone who's in treatment, that we're doing the same thing for someone that's actually in treatment on the medical side of the business too. We can't monitor and do more looking at claims for someone who's receiving mental health services than we would for someone who's actually having physical medicine performed. And then retrospective review is, I know, a big one too, because that's after the fact, going back and taking a look at those claims. And in some cases, there are provisions, at least with our contracts, where both on the medical side as well as the behavioral health side, there could be an adjustment in those claims if something is not appearing documented properly. And I want to make sure that you understand that we are doing that for all of our provider types, and not doing it all the time, but it's done because we also have to demonstrate for our accreditation standards and to the federal government that we are also practicing careful fraud, waste, and abuse standards to assure that our dollars that are being used by our members, as well as those employer groups that are contracting with us for their self-funded plans, are being paid out accordingly to contract. We can't, though, have different fraud and waste and abuse standards for someone who is performing mental health services. We have to make sure that those are the same, and we're not making it more stringent or harder for those entities or providers. And the last thing I want to point out that is being required to really look at is on exclusions. Is a health plan excluding certain services that impact people who are receiving mental health treatment and substance disorder treatment more often than someone who's on the physical medicine side? Are there exclusions specifically for experimental and investigational services only for people who are receiving mental health services? or are they doing similar exclusions on the medical side? These are the bulk of those non-quantitative treatment limit requirements the federal government is closely looking at and requiring insurance companies to report on right now. There is no template, though, on how these things are reported, and that's the challenge for us. I can tell you at Blue Cross of Kansas, we are doing all of these things, but how do we actually show that we are compliant? So like I said, we are committed to being compliant and having robust access to mental health and substance use disorder services. But when this piece of MAPIA was passed, there really was not clear guidance of what best practices are to demonstrate this compliance to the federal government. And we have to work with 3 agencies at the federal level on this: the U.S. Department of Labor, U.S. Department of Health and Human Services, and the Department of Treasury. We've been working most closely with the U.S. Department of Labor, the DOL, you may hear me say throughout this discussion, because they're the ones that are taking a close look at these employer-based health plans. And when they're doing that, it's discovered, it's actually been discovered amongst all the insurance companies, and there have been many public talks about this, as well as papers out there talking about this industry-wide challenge on compliance. And it's really because at the federal level, there's been inconsistency among the regulators and how they're interpreting what constitutes parity. We're wanting some clear guidance on how you can show you have mental health parity between medical surgical services, and specifically around these non-quantitative treatment limits. And then what should the health plan actually report to show that they are compliant? So we've actually been working very closely with other Blue plans, different states, and also the Blue Cross Blue Shield Association. And we've actually worked on trying to make it clear what 3 things we actually are looking for from the federal government so it can help solve the problem faster. We're still trying to work through this and be compliant and do the reports that we were asked to do, but we also want to make sure that we're able to demonstrate how serious we take this and not fail a report or an audit out of a confusion and misinterpretation of what we're supposed to share. So the first thing we're asking for and recommending is basically to clarify the compliance reporting structure. And that's show us exactly what a gold standard compliance test looks like, or results analysis, and best way a health plan can actually report their non-quantitative treatment limit information in the same way, so that it's easy for providers to see later on that we're compliant, easy for our members to see, also very easy for the government to see and tell us if something's being done correctly or not. We really want more guidance specifically around certain audit requests. As companies have been going through these audits, it's been happening for employer groups as well as insurance companies. It seems like the audit requests are all different and they're not the same. And that's confusing too. So if we could get at least some guidance on that, and these are the expectations on what else will be asked for to prove your compliance, then the insurance companies and health plans that are controlled by their employers could provide that information timely in a way that is transparent and does not appear to be being difficult. We really want to be able to work with the government on this. We also want to share, or have de-identified versions, again, of compliant analysis. So we don't need to know details about patients, but we want to be able to see, here is an example of an insurance plan that is done well in this process. And here's what that looks like. And so we can take a look at this and find out, are we doing what we think we're doing locally? And we do think that the Department of Labor is trying to work with us on this, but it's very difficult when they're hiring contractors to do these audits. So it's not necessarily people that work for the government and all have a standard playbook. They're all from different audit companies. So they mean to do well, but they're not necessarily talking to each other at this point about a lot of this. And that's probably because of the time frame and when this rolled out and how quickly it all had to happen. So to solve that problem, we really want to convene a working group that actually is with employers, insurance companies, as well as the 3 federal agencies to discuss this more. And that way we can actually have opportunities for mutual understanding of what compliance looks like and be more effective and efficient when it comes to reporting this information for purposes of analysis. And the last thing I really do want to recommend, and I've shared this with Amy before, we really want states to be able to lead in this conversation and ensuring plan compliance on mental health parity laws. So there was a report that came out, and I mentioned this report earlier in 2022, that actually underscored that this is a subjective analysis that's happening right now. And it's different, from federal and state parity standards, and that's making it confusing. You may not realize that insurance companies here in Kansas that are selling fully insured products must also provide non-quantitative treatment limit information and authorization and information analysis to the Kansas Insurance Department. So we're walking through the same process at the state level, and the state is doing a very good job of asking important questions, telling insurance companies to go back to the drawing board and they don't like maybe something, and this is what it should look like. And we think that's a good give and take, and it's easier to happen because they're local and they have staff that also understands what our networks look like, where we serve. That's one of the things we don't have at the federal level, and it's a little bit trickier. So we may do well with something at the state level to then find out later on that the federal level says, they're asking different questions and have a different problem. So we would love it if there was a way for states to be able to have the authority to actually manage this process, and that the federal government would use the recommendations from the state when a health plan is actually compliant at the state level. And the state can also do this very well because they do this today. Insurance products that are sold on the exchange. The state of Kansas, the insurance department looks very closely at all of our health plans, following the guidance that CMS has outlined, and CMS has provided specific templates they want us to fill out in that case. So we have to show that information there. And then our state insurance department workers verify that this is all happening correctly. And then we share all of this back again with the federal government and CMS. So it's not that we're keeping anything from the federal government, but it's being analyzed very closely at the state level. The feds, CMS will receive it too, and they look at it as well. But they also do understand that this is getting that very careful look at the state level. And that has been a good process. We would love to have something similar to that when we're working on mental health parity and NQTL analysis moving forward. So that's what I actually prepared for slides. I want to be able to have plenty of time for questions. And again, we'll make those slides available. So I don't know, I will stop sharing right now and see if there's a way we can start fielding those questions that have probably come in.
Okay, terrific. Sunny, thank you so much. Lots of information there. So I know those slides are going to be helpful for us to go back and think through what challenges you're facing as well. And I know from being on the provider side, things come out from the federal government and they seem brilliant to whomever is sitting there writing those up, and then they're not as clear as they really need to be. So my first question is from Kathy Pennell. And she said, we all know that not everyone speaks about their mental health challenges. So is there any way to know what a more accurate number might be? 3 out of 5 or higher?
We've been looking at certain reports and doing our own studies and contracting with other folks to do some analysis of the state for us, because we do care so much about this. We have a major project going on at Blue Cross right now focused on mental health and our long-term strategy for this, because we do see this as a problem that's not going to go away. It's the same as physical medicine. There will always be someone that has this challenge. We are believing that right now, Kansas is probably off worse than most other states from the data that we're starting to see. But again, it's inconsistent. It's hard to get that true assessment, but we're trying to gauge this from looking at even other claims for, say, high blood pressure or headaches and those other physical ailments that sometimes, resemble a physical problem, but we believe may be associated with a behavioral health problem, such as anxiety and other things. We look at if someone's seeking care for heart palpitations, heart problems, and now we're looking at that information and believing that is a much broader issue, and there are many more people, more than the 2 in 5 that we reported earlier.
Thank you. We have a basic one. What's a fully covered plan? What do you consider a fully covered plan at Blue Cross Blue Shield?
Good question. I consider that a comprehensive major medical plan. That's another just legal insurance term. What that means is it offers access to all the essential health benefits that are required under the Affordable Care Act. So someone can have emergency room coverage. They can see a primary care doctor, go to urgent care. They also have mental health benefits. Prescription drugs are included in that. There's typically a deductible. They have a copay to go to see a provider for office visits. But it's a robust plan. And those are the plans that we sell primarily in our markets. We think that's very important for Kansas to have. And they're fully insured because Blue Cross of Kansas bears the risk on covering those plans. So if someone purchases a plan and uses or needs to spend $100,000 on their medical care that year, Blue Cross of Kansas is paying that additional dollars. The person's only paying for their premium. Versus a self-funded plan, it will be the employer that's paying for all of those other medical costs beyond what the employee pays in for that coverage. So fully insured plans are the most popular plans typically that we talk about. But in Kansas, I also want to point out there are a lot of plans that are not fully insured health insurance plans that are comprehensive. In some of those other plans, they're going to be short-term limited duration policies, so they don't cover beyond a certain time period, or they are not plans that have to go through the same rigorous process and review at the insurance department. Those plans do not necessarily all cover mental health benefits or prescription drugs and have access to care in the same way that our fully insured plans do.
Thank you. The next question is the most recent parity compliance analysis for NQTLs from Blue Cross Blue Shield available for the coalition to review? Is that something that's publicly available?
Well, not right now. We're actually in the process of walking through that with the Department of Labor. So this is something that we have been working on and doing, and same thing at the state level. So we've been working with them on the same work. So it's not publicly available yet. And this is where, we're waiting for our grade, like every other insurance company, to see how they're doing. And we're hoping that once this is all available and finalized, then that is something that we can share. But also, like other insurance companies, there have been many companies, I believe, that have already finished theirs. They have not put them out there publicly. The goal is obviously to do well and be transparent. But right now, that transparency is happening between us and the government, both state and federal.
Okay. Thank you. So what is the time frame? Claims can be adjusted often when we talk about clawbacks for mental health providers in Kansas, because we have heard this as being a challenge for some of our providers.
It depends on your network contract with whatever health insurer or third-party administrator network that you've joined. For us, it's the exact same as it is for medical providers. So it's not we don't have a different standard in place. And I will have to go back and check exactly on this, but we try to do this timely and in the same time frame that we have for working on prompt pay and other requirements in the state. So we try to make sure that this is not out of line, or for when providers can submit claims. There's typically 15 to 18 months in that time frame, but I can find out exactly what that is for you. It's in the network contracts that people have set up with us.
Appreciate that. We'll mark that one for some follow-up. So next question, what about covering cost of gene site testing? The questioner asked, I feel like these tests are beneficial in medication costs and medication issues for people and help get them on the correct meds sooner without having to go through the medication trials and the failures.
So is this genetic testing? I'm sorry, I just want to make sure I'm clarifying what this question is about.
I think this is genetic testing. It says gene site in the type in, but I think it may have corrected for us.
Well, genetic testing is something that is not always covered under a plan for medical or mental health services. So again, it would depend on which insurance plan you have or a health plan through an employer group. And so that is not something that's automatically required. There's some conditions I know in Kansas that actually has been performed often for. And I think of the BRCA gene testing, for example, for breast cancer, but that is something that is not consistent for the insurance industry right now.
Next question, asking for some feedback from you regarding your organization's willingness to consider following the medical necessity guidelines. Feel like it would be helpful to hear from Blue Cross regarding reactions to the violation exam.
Well, certainly, let me take a look and try to understand this a little bit better. So I'm sorry, can you read? Oh, I found it, I believe here.
Yes,
So our willingness to follow medical necessity guidelines. Well, right now we're not seeing any violations on medical necessity. So if this person has a specific example that they believe is out there, that'd be helpful. Typically what happens with medical necessity, we use a reasonable person standard as far as something's medically necessary. I do know there are insurance companies that have been out there in the news outside of Kansas, inside of Kansas, that sometimes if someone was to go to, say, an emergency room, they would deny that care because they would say it's not medically necessary. That's not something we get into in our company. We use a reasonable, prudent person standard that if a person believes that this is a medical need and therefore they are, say, seeking emergency care services, they get those services. Same thing if someone's going to, say, a provider office and they're needing to demonstrate medical necessity, that's where the provider will provide information on the medical side as well as the mental health side that this person is in need of having continued therapy. I know chronic therapy is something that people have brought up as a concern, because if you have a chronic condition, it can occur on the medical side as well as on the mental health side. And in those cases, those services can be performed and covered by Blue Cross of Kansas. That's where it's important for any provider, both medical providers, physical medicine providers, as well as behavioral health providers, just document what the ailment they are treating for. And there are well-established published medical guidelines out there on what appropriate treatment would be for, say, anxiety or depression or many other types of more complex chronic ailments in the mental health world. And that's typically how we view that when it comes to medical necessity. It's about that documentation. And that's why there is the request sometimes for documentation. It becomes very apparent that someone may need to have services several times a week, every single week, because of their diagnosis. And we follow those guidelines.
Okay. Thank you. So
Can I ask a question just quickly?
sure.
So am I understanding you to say that perhaps sometimes when these services are being limited, it's because they're not being submitted under something acute rather than chronic?
It's not necessarily whether it's acute or chronic, it's about the diagnosis. So there are guidelines that we are using that have been, well published, and we do actually work with behavioral health providers to help us determine on the behavioral health side, what does treatment look like for, say, a certain diagnosis. And we understand that there could be some people who, there's different ranges and also what different people need. It may be based on their geography, based on other factors, comorbidities, et cetera. But that's all being taken into account. But it's really not about, and I'm not a medical professional, so I don't want to speak as a medical professional. So it's not about this is listed as chronic versus this is as acute. It's about that diagnosis. And I can confirm with you, because I do ask this question quite often, if someone needs to go, more than, 5 times, 3 times, whatever, how does that get decided? And that is something that is being looked at by a behavioral health professional, not by a non-clinician. And that is based on guidelines and treatments that are out there, and standards for treating specific conditions. And also, I want to reassure you that not every claim is getting looked at. We have, thousands and thousands and thousands of claims that come in to our company. So this is an automated process where claims are being paid. But there are situations where we do, to protect ourselves with fraud, waste, and abuse, we'll do periodic checks based off of algorithms. And that happens regardless of what the provider type is. And that's where then you will maybe take a look and say, okay, well, we're seeing this isn't, not necessarily in alignment with what the diagnosis is. We also encourage providers to make sure they're using the correct diagnosis. That's regardless of what the patient is there for on the medical side, as well as on the physical medicine, as well as the mental health side. There are patients that will sometimes go for physical medicine and they're really being treated for behavioral health services, but maybe because of the stigma, do not want that documented either. We want to make sure they're able to get the right care, and maybe they need a higher level of care. And we can't necessarily do that for them if it hasn't been documented that they need that higher level of care because they've already been maybe getting some type of treatment, but now that's not sufficient enough. So that's why it's so important. And that's where medical necessity, I know, is a sticking point for people sometimes, and they think insurance companies don't want to provide services. It's really about being able to make sure that the right service is available. So if someone needs a higher level of service, that's fine, but they need to be able to use the correct billing code or the correct diagnosis to be able to get that type of service.
So we have, our next question is a little bit of a multi-parter. So bear with me as I read it. So the person who put this in, I'll do my best. So we have a therapist who's providing both in-person and telehealth sessions in Salina. And it looks like what they're finding is the time frame for a provider to be credentialed with an insurance company is approximately 2 months. So the question then is, what are the barriers to providers getting credentialed with insurance? So in your experience, what is it that holds that up, doesn't meet that 2-month time frame? And what can be done to facilitate the credentialing process so that providers can meet with their clients sooner?
That is a great question, because that is a big thing that's happening right now. And there's two pieces of this. One is just, I would say, more of administrative and making sure that the application and the questions are completed fully. That sounds simple, but it's not always simple, because there may be questions that are asked that the provider doesn't have the information for. And if the provider sends information in that's incomplete, then we stop that clock again. The information and the request goes back out, and that could add to that delay. There's also a technology side to that that is actually making it a little bit difficult right now. And Blue Cross of Kansas has been in this transformation of the system that we use for actually loading providers into our network. And we're manually having to load providers that are new, and that is taking more time as well. So we are almost done with that overhaul process and modernizing our systems. We want to make sure that we don't have technical glitches like we've heard of in the news recently. So that's why we're overhauling the system and doing that. But that process does take more time and has added additional time. If there is someone that is trying to get into the network and they're feeling they're having a struggle or challenge, I welcome them to contact me, send me an email. We are prioritizing some of those providers because we're hearing about that. And I think, Audrey, you've heard about some of that too. So if there is someone that we can keep eyes on and make sure that they've done everything right, and it's a technology challenge, we're making sure we push those forward as fast as possible. So I apologize for anyone who's having that delay, but it is very important for us to make sure we're getting you in there so that you are appearing correctly to all of our members, and that also that we can make sure that you're going to get reimbursed properly too.
Thank you. So the next question, because we're going to ping pong a little bit, is what are the NQTLs related to SUD services, especially for those who continue to relapse?
Well, all of those NQTLs are being looked at when it comes to every single service. So that's part of the challenge, as you can imagine, because when you think about procedures and services, we're talking thousands, right? And I can tell you that the questions we've seen thus far that are popular and also heard about from other insurance companies, it is about the prior authorization processes. It's about, whether or not there are network providers. In some cases, this is the challenge you have with someone who's working with the federal government. They mean very well, but explaining to someone working at the federal level that in certain parts of Kansas, there may not be a local provider that treats a substance use disorder or has access to the medications that people are looking for. Some of those are the challenges that we're facing as an insurance company, as well as the state, as you know. So that's where some of those questions are coming up. But I can tell you that it is for a substance use disorder and every service, they're looking at all of the different pieces and components, and then some. That's where we're also getting extra things that are popping out of from different auditors that are not consistently known amongst the industry. And we want to be able to answer those up front and not wait till later on and then have a process where we're still going back and forth. We want to be able to be upfront and give them the information they need. And if there is something special that they're looking for, we should know that up front so we can get that for them.
Thank you. So the next is a more provider payment question, sort of a big picture question versus very small picture. But the question is, why don't mental health practitioners get paid a salary / reimbursement rate comparable to people like physical therapists? People graduate with a master's degree in social work or MFT with tens of thousands of dollars in debt and don't get paid nearly as much as other equally educated and qualified positions.
Well, I can't speak for other insurance companies, but I can tell you what we try to do at Blue Cross of Kansas. And we do take into consideration the amount of time someone spends on their education, the amount of time they spend typically to receive their certification or license. We do know it's different. You may have your education completed, but for certain programs, you're required to work supervised for some length of time to also prove that you are efficient and able to perform those services. So we take all of that into consideration. And it's not necessarily for us that this person may be a physical therapist versus this person may be a licensed clinical social worker. It truly is about matching up education and time that it takes to actually be able to see patients. We also do take a very close look at behavioral health services, and we actually have adjusted how we do reimbursement for that in many cases. So we have additional dollars for those providers in rural communities. In telehealth, we actually are, we've added a 5% increase on the provider side for anyone performing behavioral health services in telehealth. So that's more than a physical therapist cannot perform a behavioral health service. So we are recognizing that there is a need for behavioral health providers to be paid appropriately. But also, I can't speak for others, but I do know that we often hear from providers in the behavioral health community, the Blue Cross of Kansas is actually paying more for behavioral health services than other insurance companies. So that's anecdotally what I hear quite often. And many providers will say, I don't take any other insurance. I only take Blue Cross, and that's because you pay us more.
Okay, interesting. So another payment, but now this is more from the patient side. You said earlier that mental health and behavioral health care is treated by Blue Cross as a primary service, not a specialty. So does this mean that patient co-pays are at the primary provider rate? For example, my PCP fee is $5 per visit. If mental health, behavioral health is on parity and is considered primary care, shouldn't 1, referrals not be required, and 2, patients only pay whatever copay they would pay their primary care?
Well, if someone's talking, and I'm going to keep this at, it sounds like a outpatient, office visit type situation. there should not be a referral happening for that. That should be able to happen without having a referral. So if a patient does have Blue Cross of Kansas and they're having that situation, I would invite the patient to reach out to me offline and we can talk about their situation, because that should not be happening. They should be treated as regular office visits, and they should be able to receive that office visit and pay the same copay for that. There are other Blue Cross companies, so I want to point that out, and I can't speak for all of them. They're independent and separate from our companies. But I can tell you that for us, a behavioral health professional is not considered a specialist, and they may be called a specialist, but their copay is the same as a primary care visit.
So this is a little bit broader question, and I think it's probably going to have to be our last question. We're coming up on the hour. How do you feel we can ensure parity and consistency of coverage and care for conditions that don't have universal definitions or criteria, such as treatment-resistant depression?
Yeah, it's very difficult. And I would say in the behavioral health world, things are evolving so fast right now, which is great. But at the same time, that does leave this ambiguity out there that has probably created a challenge for both patients, providers, and as well as insurance companies. So when I talk about challenges, it's not that we're frustrated in any way. We're really just trying to make sure we do things timely and efficiently to get people access to the care they paid for. So what I really would love is if we did come up with some state solutions on this. I know we've had working groups before, and if we do have some treatments that are becoming more, I would say, often used or showing that they are also difficult to define what the proper treatment is, we work together on that and come up with some common definitions. And that's back to having the state control this process of analysis. So then there is that, here's what the gold standard looks like. Here's what the insurance company should be offering. So that they can make sure this is in parity with medical. We get frustrated too, because sometimes things are not very clear. And it's just about us trying to be good stewards of our dollars, for the member dollars that we receive, but also being able to stand by the services we're paying for.
Well, thank you so much. We do have a few outstanding questions I think we will share with you and maybe get some follow-up from you. Some of them are a little bit more complex, I think may take a little bit more thought to answer than we really have time on this webinar. And thank you so much to everyone else for joining us today and learning. We all, like I said, this is always an opportunity for us all to learn from each other, to ask the questions, and to see if we can't move forward to do good things for the people of the state of Kansas. Amy, I will turn it over to you to sign us off.
Okay, thanks everybody.
Thanks, everyone.
Bye-bye.